and then I'm going to link.
This silence is making me feel awkward.
That's the silence, huh?
Not real good with silence, especially when we're all just kind of staring at the screen. It makes me feel a little weird, but so I thought I'd at least just say hello.
All right.
Hello.
Okay, here we are. So hello, everyone. I am Lynn Crawford from the Hope Dementia Support Groups, and we have a panel for you tonight to discuss home care and placement. So I'd like to introduce everyone, and I'm going to start with Tamara Russell, and she'll tell you a little bit about her organization, and then we'll go from there.
Okay. Well, hello, everyone. I am Tamara Russell, and about a decade and a half ago, I started my business in Clark County and then altered working with other agencies, educating and learning and building relationships. And just recently pulled my business back together, working with just myself and not other agencies in the same way, although I'm collectively trying to get us all together as a co-op and work in the community together, helping each other know more about all of our options. My business is Thrive Care Solutions. And as I mentioned, I've been here doing this for about 15 years. And I think some of the challenges that have been out there, and many now with the COVID situation, not being able to go with families into communities. I guess I should say I'm in referral service placements, not in home care. So we have other services or companies here that service that area. But as a referral service, it's been a little difficult now with the COVID giving, I guess, that support, holding hands and taking people where they need to go and being with them to help them with choices. So we're doing a lot of this kind of thing with Zoom and Messenger and a lot of phone calls and so forth, working with the families that need help for their spouses or their parents, siblings, whatever the case may be. And a little bit of extra about me is I have an animal rescue, also about as old, almost as old as the work I've been doing here in the county. And so that ties in with seniors a lot. Just this last 2 weeks, we've taken in 3 senior dogs, 3 dogs from seniors, and the dogs just happen to be senior as well. Because of the person that had to move either into a memory care or whatever situation. And so I'm not sure if that's, I'm not quite sure if that's terrific since I get them. I'm the one they call for that. And the sad part is I don't always have fosters, and we're a foster-based rescue. So we always are reaching out into the community to have help with that, because there are a lot of people that do have their animals, and it's therapy for people to have their animals. And when they can no longer keep them, it's a delicate situation. So I guess that's a little bit about me. What I wish that people knew or know is that when it, not so much for in-home care, we try to help connect people for in-home care, because our goal as agencies, our credible agencies in the community, not to get people out of their home, but to keep them in if possible, as long as they're safe. And if they have to leave, what I wish families would know is that there will never be the exact home, just really great care. That's what we're after. So if that makes sense. I guess that's a little bit about me, and probably too much. I'll shush up now.
So our next panelist is Christina Hanksler with First Choice Advisory.
Super close, but not. It's
Not?
thanks, Lynn. It's Christina Hanksler. It's a married
Hanksler.
name. Yeah, I tried to give that up when I married 26 years ago. I came from a Nelson to a Hanksler, so it's just what it is. So I'm trying to be good about that, right?
Now I know how to say it.
So I work with First Choice Advisory Services, and I'm a referral agent here in Vancouver. And my partner in crime is Amanda McCallum, and she does marketing for us and outreach. And I joke around and say, she tells everybody I'm amazing, and then I have to do that. So there's no pressure at all at that. First Choice Advisory Services has been in business for over 27 years. And within the last 3 or 4 years, we've opened here in Vancouver. So we've been lucky to get to know our partners and out in the world last year, and did a lot of groundwork in getting to know all of the different communities, assisted living, memory care, adult family homes. And so when COVID hit, I was grateful that we had all those relationships in place, because we had to really pivot and look at doing business a different way. Like Tamara was saying, we definitely offer a concierge service where we're talking with families and just holding their hand through the steps, all the steps, whether they're calling for in-home care and talking with them about the other options that are available and some of the differences between the different options, and giving them information to independent living, assisted living, memory care, adult family homes. And so certainly with COVID, stopping anybody from visiting, that's really hard on an extrovert like myself. But we were able to be creative and work with different communities about getting tours online, or sending pictures, or meeting safely outside so that they could have an idea. So it's been a real challenge both for us in the industry to try to make those matches, but also to help families make those decisions, especially when they are imminent and they need to make a choice, but they don't have the same ability to go in and touch and feel and see everything when they're making a choice. So we'll just ask people to trust that based on what they've shared with me and what their preferences are, what their concerns are, that I'm trying to make a match based on what's available out there within their price point as well, and then delivering that to them so that they can make those choices. And I'm here as a guide. One thing I wish that some of our families knew is that we are here to help, and our service is free. We're free because we have contracts in the community with all these different providers. And so no matter where you decide to go, our company will be paid a referral fee. One thing that sets our company apart, I think, is that we don't bill immediately on that first day. We wait 30 days to make sure that it's a good match and that everything is going the way it needs to. And then we break our billing up in 3 different parts. So for a small, adult family home provider, it's a big risk to have to pay a referral agent and not know if that placement's going to work out. So while that's not so great for me as a sales lady, waiting for commissions to come in, it is the right thing, and it works out nicely and feels really great to do the work and to see those matches come together, and then get feedback from families and communities about what a great match we were able to make. And I think that is all for now.
Thank you. So Alice Wilkinson of Oasis.
Hello, I'm Alice Wilkinson with Oasis Senior Advisors. I'm a referral professional, and so I do what Tamara and Christina do. My commitment is to work with families and act as a guide to navigate this whole process. Whether, we say one call, many answers. So I have a lot of resources and strive to be a really good resource for the families. And of course, with all of us, the challenge with COVID has been not being able to meet families face to face, not being able to accompany them and go on tours and really develop that relationship, because that's why we do this. I love building those relationships and being there face to face with them and helping them, free as well, to navigate through all of the options they have. And of course, we do have a lot of great home health care companies who do a great job to help people age in place, but that's sometimes, due to safety or health or other reasons, a placement is necessary, and that's where we come in, is to make it as smooth and painless as possible, and giving information. And our tagline is, because the right place means everything. So we don't want people moving after they've gone somewhere. We want them to be the right place. So that's really, really important to us. So yeah, that's my title. I'm a CSA certified senior living advisor. And as far as what I would like people to know is kind of like what Christina said, we're here to help, trust us. We all pretty much work the same way as far as compensation and whatnot. So we try to be very unbiased, and with the knowledge that we've accrued through doing this, make those good fits. And I just wish people knew about us and knew that we were here to help, because often when we get the phone call, it's in sheer desperation. And I just wish I could have started with them earlier in their process.
Thank you, Alice. Thank you very much. Mm-hmm. Before I go to the home care agencies, I want to ask everybody that if you think of questions as our panelists are talking, if you could please put them in the Q&A box, and then we'll be able to ask them for you. So we will start then with Joey Yorchek from Elfin Services.
All right. Hi, everyone. As she said, Joey with Elfin Services. So we are a locally owned home care agency, as well as a care management agency. So we essentially have a team of caregivers to help support people in what they consider their home. For most of our client base, they are actually living in their own homes, but we certainly have been in situations where they need extra supports, and so we are going into facilities. And then we also offer care management, and our care management team essentially helps to, there gets to be a point where things just start to get out of control, whether for clients or for families, and they need somebody to kind of step in and help navigate and help coordinate a lot of the care that the person needs. So we have a team of care managers who can step in and essentially be that advocate and that liaison for families to, whether it's even working with the home care agency to make sure that caregivers are doing what they're supposed to, and they're taking care of tasks that they're supposed to. And I would say, as a locally owned, as a locally owned company, we've been around since 2001. So it's kind of interesting. I've been thinking a lot about this, that it's 2020 and we're getting ready for our, 20-year anniversary, and what a 2020 it's been. And that's a whole nother educational opportunity. to learn about how I feel about that. You know, as a locally owned company, I would say that, you know, with as my position with the company is the agency administrator, and the, you know, some fancy title of director or supervisor of direct care services. So essentially my job is to make sure that we're doing what we're supposed to with the Department of Health and following state statutes and compliance and regulations and, you know, all the boring things that nobody really wants to hear about because nobody really likes doing them. But, you know, I mean, I certainly love them, love doing them. That's why I do what I do. So I kind of work on a different level in terms of what we do as an agency. But part of that role as the agency administrator and the supervisor of direct care services is also just making sure that, one, that we are staying in compliance with things, but that we're also helping to provide proper quality care. And so we're also looking at things from, at least from my standpoint, I'm looking at things from liability standpoints, and then also sort of helping to provide fresh ideas when it comes to caring for people, reviewing the care plans to ensure that we're, you know, we're really paying attention to some of the things that we should be paying attention to. And when it comes down to COVID-19 and some of the challenges that I would say, I mean, I can sort of put it in a very simple way, and that is, just like everybody, we're concerned about the safety of our employees and we're concerned about the safety of our clients. And it sort of just boils down to those basic, how do we protect our people? And obviously there was a lot of information going back and forth and new things being released all the time. And, you know, and I'll say as a home care agency or as somebody in the healthcare world, you know, we certainly always paid a lot of attention to precautions and, you know, a lot of the things that kept coming up about, you know, washing your hands often and sanitizing and being safe. And, you know, we're kind of all in the background going, well, yeah, we do those things on like a regular basis, but, well, yeah, but this is more serious. And so, you know, again, I think it was just really, it was more, the challenge was more finding a way to get clients to feel comfortable, especially with what was really going on the outside and not really so much on the inside, because I think that clients had a lot of trust that we were doing all the right things and caregivers were showing that they were doing all the right things when they were going to shift. And so, you know, I think that it really was more of just figuring out how to make everybody feel comfortable. And of course, all the paperwork pieces, those to me were fairly simple. You know, all the stuff that you now have to have in place. But, and of course, you know, the supply issue, that was a problem there for a while, and making sure we had enough of the PPE. And so, you know, thank goodness, I wish Sarah was here because Sarah's also part of Caring Closet, and, you know, truly thank goodness for Caring Closet and getting the masks from them. You know, I reached out to Sarah and I was able to get, honestly, we were able to get several hundred masks. Not only for my team, but they also were able to benefit a lot of other places that really just needed those. And, you know, luckily we had enough, you know, we were smart enough to stock up on a lot of those other supplies, and you just keep them upstairs in the supply closet. But there were certainly things that we just couldn't get anymore and started to run out of. And, you know, so really those were kind of the big challenges. But, you know, what I will say is that there have been, you know, a lot of negative going on. There's a lot of negativity and a lot of scare and sadness, and, you know, it's unfortunate to see all the you know, the people dying, and just everything that's been going on has really been a big challenge. But, you know, I'd like to say too that there's also been just a lot of positive, in the sense that there's just been a lot of opportunity to sort of take a step back, and really reflect on how you are operating and what things really look like on a daily basis, and, you know, really taking the opportunity to find out if there really is, you know, how do you really improve what you're already doing, and how do you make it easier for everybody? How do you make families feel comfortable? And so for me, COVID has kind of been a 50-50. It's been, you know, there's been definitely the challenges, but there's also been a lot of positive that have come out of it. And I think that I'm feeling really good about where we are at this point and all the things that we've learned just in the last 5 or 6 months. And, you know, I really feel confident that this has been a learning moment for all of us. And it's also helped to sort of just adapt and grow the business to, one, get with the times, but then also how to, you know, really step up on the quality of care that you're providing, and, you know, make it easier for families, because that's the whole goal, is to make it easier for families to care for their loved ones. And so how do we accomplish that? And I really feel great about what we've done in the last several months in terms of doing that. And, you know, and that's all part of the, you know, next year, 2021, and anniversary and 20 years. And, but, so, did I miss anything?
What you wish that people knew before coming to you?
What do I wish people knew before coming to me? Well, I'd say, I guess, you know, what I always sort of applaud us about, or what I really appreciate about me and my team, and, you know, I guess sort of some of the flexibility that we have as, you know, a locally owned company. You know, I mean, we really don't have, aside from, you know, some of the statutes, and then again, this is not meant to, you know, to say anything negative about Julie and Homestead or anything like that. And I'm only saying this because, you know, I think that we just have a lot of flexibility in terms of what we do, and then also pulling in the care management team that we do have, and being able to sort of offer that separate service as well. Because sometimes people think they need one thing and then they find out that they actually need something else. And so sometimes it turns out they're calling us or contacting us for caregiving, and it turns out really all they needed was someone to help coordinate their care, and therefore going to care management services. So I think what I would like people to know is that, you know, again, as a local company, we have a lot of flexibility, and we're really able to adapt to people's needs and what they want.
Excellent, thank you.
Yeah.
Julie Williams from Homestead.
I love you, Julie.
Hi. Hey there. Thank you so much. I appreciate it. I'm Julie Williams, and I'm with Homestead Senior Care. I have owned the franchise since 2006, so this is 15 years this month, which is so exciting for us. Challenges of COVID, I would say for us, is the concern right off the bat was just loneliness and isolation for seniors. And what we did and how we kind of dealt with that was started marketing our services with the GrandPad more. So we have a virtual way to connect to people in their home if maybe they don't need a caregiver, but being able to connect face-to-face with someone, or be connected via this GrandPad has been something that we've been able to offer to clients, that current clients, so they can keep in touch with their families. And then also for the clients that may not need caregiving services, but just being able to stay in touch with folks and people can check in and get eyes on. The things that I wish folks knew really is probably how predictable aging declination is, or how the decline is predictable. Not everybody's situation is the same, not everybody's trajectory is the same, but often we see signs that are predictable of what the needs might be and what the next level of care might be, and how to keep someone safe if they just need a little bit of help, maybe just someone checking in a few times a week, helping with meal preparation, or making sure that their medications are being taken on time. Those are important things for our seniors, and just having a little bit of help with that is preventative and really cost effective, and it keeps people out of the hospital. So just knowing the predictability of aging, and I think we can kind of all attest to it because we see it happen, especially, you know, we'll start with home care, a client, and then they'll progress, and then they'll need more care than we can provide. Or it's it's more care than really becomes affordable after a certain number of hours. Looking at an assisted living or an adult family home becomes more affordable, and that's the next step. So we see that pattern and we work together. That's why you see all of us we work as a team, because we each know that one day the next level of care might be needed, and we need to know the folks that are providing that so they can help our clients along the way. So thank you. I appreciate it. Appreciate you having us here.
Thanks a lot, Julie.
Mm-hmm.
And next we have Ginger Barnwell from Cdm.
Hi, my name is Ginger Barnwell from Cdm Caregiving. I'm actually in human resources. I've been in the industry for about 10 years now, but only with Cdm for 2. The challenges, we've seen a lot of challenges. Cdm Caregiving Services offers, most of our clients were nonprofit. We have a Medicaid contract, so most of our clients are on a Medicaid service. About 90% of our clients are. Our challenges early on in March were a lot of our clients were really afraid to have a caregiver enter their home. Even with all the PPE equipment that we did provide, was really scary for our clients. We had a lot of people put their services on hold during that time period. Months have gone by, so people are coming back on board. The other challenge during COVID was a lot of our caregivers were very afraid about going into a home. And that's been a huge challenge for us, still is. And we're working through that. We have seen our caregivers as well as our clients have decline. Depression and extra support is really needed for all of them right now. Just someone to talk to. With our clients that are currently didn't want people to come into homes, we are placing calls to them to check in to make sure that they're doing okay and checking in with their family members as needed. But it has been a huge challenge. It is getting better, but early on especially has been really difficult during this crisis. We've been lucky that we've been able to provide PPE equipment, not only to our caregivers, but to our clients. We have masks for all of our clients. So we've been really blessed that way. One of the things that and I think all of you sort of hit on this about a wish. One of the things, just from my short time in this industry, as well as just personal experience, is early on having conversations with your loved ones or someone that's in your corner to start discussing, aging and what that looks like and what your wishes are long term. A lot of people want to stay in their homes as long as they can. Obviously, sometimes it's not feasible after a point, but to start looking at that and talking and having open discussions with your loved ones about what your wishes are, even financially, what does that look like? I think it's really important, all of us as a collective group really discuss that. People don't want to discuss it, but it's important to do. So that's really my wish. But with COVID challenges, I think the challenges with our clients and our staff is getting better now. So I feel blessed about that. I think that's it.
Okay, now that each one of you have had the opportunity to speak, is there something else that you're thinking that you would like to bring up before we actually go into our questions?
Just well said by everybody, honestly. I mean, I think I like what Julie said about us being, a team as, community partners, because, it's like we always say it is like there's not enough of us to go around for the need. And I just really like collaboration that all of us have, and I appreciate each and every one of you. So that was it.
Wonderful. So some questions for you all, and whoever would like to answer, please feel free. So for the caregiving agencies, is it possible to get a caregiver who's had experience with a specific chronic disease? For example, with dementia, someone who is familiar with dementia and knows how to deal with it.
I can take that. Yes, if caregivers have been in this field for 10 years, they've probably experienced most of the chronic conditions that our seniors face. And then what we find is if a condition that comes up that's unusual or unique, then what we'll do is do some Google research on that from Mayo Clinic website on the condition, and then share that information with their caregivers so they're up to speed on it. But a lot of chronic conditions, caregivers that have worked with us for years or have been in the industry for years are very familiar with. And then we also have in-house training that we can provide for the caregivers on those chronic conditions as well.
Thank you. So a specific question for Joey. How do you create a managed care plan? Who all is involved?
Yeah, so it has to also do with the tool that you use to create your care plan. So I think one of the important things is having proper software, and it's essentially a customer relationship management program. And by having that, you're able to input important things about what sort of things they need in terms of activities of daily living, instrumental activities of daily living. And of course, you can notate a lot of other things like, what does their daily routine look like? What are some of their preferences? What do they like to do? What are some of the foods they like to eat? How are they with showering? And all the questions that come up in terms of, the care plan. I mean, and again, most of us know what that is here. And so what happens with that document or that care plan is that's the tool that caregivers can use to review what the plan is and what they're supposed to be doing. And it also gives them a little more background in terms of things that I was just talking about, of hobbies and activities that they like doing or foods that they like. And the way that we have it set up is that we actually have our care management team. And so our care management team are the ones that are managing those care plans and the ones communicating with families, as well as our caregiving team, which are going out and essentially working with the client to make sure that, sort of like Julie touched on, is if you've got somebody who has, a specific illness, and most of the time you're gathering that information about caregivers as time goes on. So you have an idea of which caregivers are good with dementia, which caregivers are great with Parkinson's. So those are the caregivers that you're sending out to work with somebody that, say, have a specific illness or disease. And so, and then allowing the care management team to easily see those things, communicate with families, and just make sure that caregivers are following through with what the plan of care actually is.
Excellent, thank you.
Mm-hmm.
So for the caregiving agencies, would I be able to pick a caregiver?
I can answer that from Cdm Caregiving. You don't get to pick your caregiver. We do have preferences for what a client's, what they're looking for, and then what the caregiver preferences. So they don't get to pick the caregiver.
Okay. Other perspectives?
Yeah, this is Julie with Home Instead Senior Care. We go in, do the assessment, and try to get to know the person as best as possible so we can do a good match. But I also say that if you're not looking forward to that person coming, it's not the right person, and we need to make the change. So if you're not looking forward to it, doesn't mean you don't need them. It just means you need a different person, because that's one of the key pieces is you need to have a good fit. So I think that's kind of where we're at, but we can't discriminate. We can't pick a male or a female, that type of thing. But the important thing is that the relationship and the fit is good and in the long run.
Okay, great, thank you. So how would I know that the caregiver that is coming to my home is qualified?
Take that. I think I'll take that. This is Joey from Elfin. You know, when we're going through the hiring process, we're essentially screening the person. One of the requirements is that the person is, you know, has the specific certification to work for us as a licensed home care agency. And of course, they go through the background check, and they certainly go through, you know, all the initial things that we need to make sure that, you know, they're who they say they are. But part of that is, you know, and this is kind of, you know, this I would say differs from agency to agency, because the way that the state has it worded about how you sort of assess this, it's not like they give you a line item by line item answer of how you would assess somebody's abilities. So, you know, I think that as an agency, you sort of create your own criteria based on experience of what are the things that you need. And again, coming back to even talking about, do you send a caregiver out for a specific caregiver out for specific illness or disease? You know, we have we do an assessment during the second interview. And we actually make them do things like we make them do transfers. So we make them put on a gait belt, and we make them do a transfer, and we make them do blood pressure, and we make them do sort of a lot of the skills that you actually learn in CNA school. Because we all know you can go through CNA school, and I tell people all this time, I'm a CNA, but I wouldn't trust me on a complicated case. I mean, I can handle basic level, but certainly I hope that you have it in the criteria matcher that I'm not designed to do things like tube feedings and some of those more complex cases. So, you know, really it's about developing your assessment and testing them on what you want them to have the skill sets with. You know, I mean, really, what do you need? What do you provide? And also it gives you the opportunity to learn about personality. And so you can kind of gauge personality, because again, we're trying to, and that's one of the biggest challenges too, is you're always trying to match up a person, a client with a caregiver. And you have some caregivers who are very quiet and they're very introverted, and you have clients who love that about them. And then you have them go to another client, and that client is complaining because they don't say anything. They don't talk enough. They're boring. So, you know, I mean, you really have to kind of go through. And again, I think this has a lot to do with the software or what tools you're using to organize and keep track of all this information. And that really helps to be successful when you're sort of pinpointing the type of caregiver that's going to work best for the client. And a big part of that is the assessment. You learn a lot about a person during the assessment, and we're all people that pick up on behaviors and pick up on the tiniest of things. And so that all becomes part of that assessment when you're deciding who you're going to send out.
So along with that question, are all of the caregivers that work for your agencies, are they certified nursing assistants? Are they home health aides? Tell us about what they are able to do. Can they give meds? Can they do tube feedings? Can they change catheters? All of those things.
Go for it, Julie.
All right, great question. Well, so there's a mix. We've got certified nursing assistants, and we have home care aide training caregivers that are certified in the home care aide training program. And then we have caregivers that have been doing it so long that they were grandfathered in when the training the training law became a law in 2009. So there is a mixed bag, but we can do certain, so we're non-skilled is what we are, and we can be delegated to do, to crush meds. We can be delegated to do tube feeding. We can be delegated to do diabetes care. But we have to have a nurse come do that assessment, and then the nurse will come do the training of the caregivers. So there's additional costs that get added on for anything that would be a nurse delegated task. And they have to be predictable, stable and predictable.
Any comments?
Don't ask for the definition of that.
Yes.
So, Ginger, any comment about that?
No, it's the same thing as we have CNAs, we have HCAs, we have, you know, we hire at our agency, we hire people that are brand new to the field. So we put them through home care aid training, and, you know, they can, when we hire them, they go out and do light care until they've gone through all of their home care aid training. But, you know, the same thing as, you know, we can have a CNA or HCA delegated, but a nurse would oversee that. So I think that's pretty standard for all of us.
Okay. And do they do housework?
This Ginger, our caregivers do.
Okay. Julie?
So do ours. Yes, we do.
Okay.
It's not our primary focus. If a client calls us and they just want someone to come in and do a glove type of cleaning where they do glove inspections, that's not really, we're going to refer them to someone that just needs to a housekeeper. But we absolutely can do housekeeping, light housekeeping, dusting, vacuuming, meal preparation, grocery shopping, all kinds of things.
Okay. And do they ever go to the doctor with them?
Yes. And we have a doctor visit form that we always send with them. And that way it gets filled out by the nurse or the doctor themselves on what the next steps are, when the next appointment is, and any changes that may have occurred. And then we can get that to the family members if they're out of state or not nearby, so they can stay up to date on what's happening with their loved one.
Excellent. And to go along with that, Joey, so with your case managers work with the physicians related to the medical plan?
Correct, yes. So most of the time the care management, we end up getting a release of information. And so most of the time we're actually on people's medical profile, our care managers are in their profile in their system. And so, we'll gather medical records if need be. And, we just do, it's more of a higher level coordination. And so then of course, a lot of times it's then if they get follow-up referrals, we're calling making the calls for the follow-up and setting up all the appointments and, notifying the family that, hey, we made the appointment for these dates and times. And so that's essentially what our care management does. And then of course they will also attend doctor's appointments and things like that. But, with having the caregiving and the care management side, we do find that, if it's a simple appointment, most of the time it's just a caregiver who's riding along, taking them over to the appointment. And same thing as what Julie was talking about, where, some documentation, bringing it back. So like I said, sometimes the caregivers will do that, but then the care management team can also do that. And then, like I said, sort of continue to follow and make some of the phone calls and scheduling things that families just don't want to deal with.
Okay, thank you.
And I just real quick want to say, I see Beth Paul chimed in on the chat just about stable and predictable. It was more of a joke, Beth. But it's a good point. I mean, she says the short answer is it means no acute illness that requires urgent, emergent, or acute medical care. So thank you, Beth.
And I was going to read that, so I'm glad that I'm glad you saw that and cleared it up. So again, talking to the home care agencies, customer service response times. So how quickly would you be able to get somebody out there when it was determined that you know, the 11th hour, this person needs to have somebody to be with them?
I
I can
go ahead. You go.
Okay. Right now for our agency, there is going to be a wait. We have, with our Medicaid contract, we are always signing on new clients. It's just a matter of being able to staff the clients appropriately. So there is going to be, for us, a wait time right now. It wouldn't be, you couldn't get someone right away. Unless it was not a permanent, it would be a substitute caregiver.
Okay. Julie?
It depends on the day of the week. It can fluctuate. In this business, you know, you might have a client where you've got 3 or 4 caregivers providing care, and that client moves to assisted living or a adult family home, and then all of a sudden you have 4 caregivers, and that could happen in a short period of time. But right now it's a challenge. We like to be able to start within 24 hours. But right now hiring is a bit of a challenge. Getting enough caregivers to be able to staff the way we like to has been one of the challenges during COVID as well. But,
Okay. So Joey, anything?
I like Julie's answer. It depends on the day. I'd like to say it was a smooth process, but I think really Julie kind of just said it all. It's a challenge, and sometimes you can start and, you know, oh my gosh, wow, we just lined everything up and we can actually start tonight. And then other times it's 24, sometimes it's 48. But what I can tell you is that the state says that if you sign a contract that you are supposed to start services in 7 days. So there's that side of it. So don't sign the contract until you know for sure.
So 7 days is the rule of the state, huh?
Yeah, so, well, they essentially say, like, if you're signing the service contract, you are supposed to be starting services in 7 days, and if you're not starting service in 7 days, then essentially having documentation of why you didn't start. So.
Got it. So a couple more caregiver questions, and then we'll get to some tough placement questions, you guys, so don't sleep on me here. How do you introduce a caregiver to a care receiver if they're unwilling to participate? They don't want somebody there. Does that ever happen?
I mean, I obviously have input, but Julie?
No. Well, it depends. So if it's
probably
dementia,
the same answer.
Yeah, probably the same answer. If it's dementia, you can get creative. You don't have to say it's a caregiver. You can just say it's a friend of mine or a friend of Joe's or a friend of, you know, the husband, so you might just do it in a clever way. Now, if it's a completely, they're completely cognitive and they can answer any questions, etc. I just say it's not a permanent thing. Give it a try. See if you like it. You know, that's the one nice thing about home care. You haven't moved. And you can, and there's really it's not like you've got a month's rent involved. So if you need to stop care because it's not your thing or dad doesn't like it, you're not out a lot of money. So that is the nice thing about home care. But I do think that if you can get the right match, get the right caregiver in there, you can make magic. But it doesn't always happen, as we know. And then, of course, they can become really stubborn too, but I understand where they're coming from often.
Speaking of magic, describe your most challenging or rewarding client or case, and what did you learn? And I would ask that of all three of you.
Mhm.
Well, I mean, I have one that, you know, we've decided that it's kind of funny, but I mean, I'll start since I'm already talking. But we actually, just in our mind, we've got a, you know, this is our chart of level. And so we've got down here, we've got this case, and we have a name, but I'm not going to say it out loud. Down there is just very basic, straightforward, great family, great everything. And then up here, we've got the other case that is almost like the case from hell. And oh gosh, can I say that? Too late. It's just one of those cases that I'll have to say, I mean, you certainly, it was really frustrating. There was a lot of challenge, a lot of hurt feelings, a lot of tears, a lot of liability concerns, a lot of breaking of the state rules. And a lot of that stuff was just out of our hands while we were working with this particular client. And, you know, I'll have to say, like, it went on for a full year. And it was a really big challenge for us, but I would not trade it for the world, or I wouldn't trade it for anything, only because the experience we got from it and the things that I think, again, we really learned about us as an agency and what we were capable of doing. It was a really complex case. And, you know, again, I think that's the other thing, is that you really have to assess that what you've got on board and what you can handle. And we really want to help people. We know that our hearts are always in the right place, but sometimes you just don't have the right skill sets. And I think you just really learn to say no, or say that, no, I can't do that. And I'm thankful for what we went through, even though it was a nightmare. And I think for months after we finally got rid of the case, we actually all kind of had like PTSD. But it was such a great experience, and we learned so much about our team, and we learned so much about so many different things, and how we communicate, how we work together, how the caregivers handle things. I mean, it really was like this great bonding, learning experience that we had. And so I think that as hard as it was, and I mean, nobody likes to take those kinds of cases, but at the end of the day, I was really pleased that it landed in our laps and that we got to experience it, just because it taught us so much moving forward.
How about you, Ginger? Does anything come to mind?
The only thing that has come to mind recently was a client was really not wanting the care, but turning caregivers away, would have a caregiver for maybe a week, and then not happy with that caregiver, turn that caregiver away, and then we would restaff each time. And that was going on for a long time. And we almost had to stop services because we couldn't staff this person correctly. We hired someone that had a lot of experience recently, and tried to put this person on staffed her with this individual, and it's been night and day. The client's really happy, but it took us months and months to get to that point. And you know, now it's working out famous. It's been great. So that's been my challenge.
Julie, anything come to mind?
Oh gosh, let's see. The challenges seem to kind of repeat themselves over the years. So again, there's some not unique, but I think the hardest thing is when families are trying to undermine one another. When a sister and a brother have different ideas of what care is supposed to look like, or how much it's supposed to cost, or where it's supposed to be held. And not working together as a team can be one of the more challenging type cases. The other challenging things would be personalities. You know, just because you're, you know, in your 80s doesn't mean that you're automatically sweet and kind. And to me, the way they treat caregivers, where they treat human beings, is really important, because my caregivers are important, and I need to keep them as employees. And So if folks can't treat my employees with dignity and respect, then they get kind of put on notice, because we all try to work together, be kind to one another, and treat one another with dignity and respect. So that's another challenge, is if someone just doesn't have that basic, treating other people kindly. And it's a different to be in a grumpy mood or be a curmudgeon, because I love that. I'm just talking about meanness. And I can't risk losing caregivers, so I often will put the client on notice that it might be time to find another option.
I'm actually glad to hear you say that, because you're right. Just because you're old doesn't mean that you have to be mean. So looking at our placement folks, so when does someone come to you for assistance with placement? And don't everybody speak at once.
A lot of times it's after a fall or after a hospital stay, or an acute or chronic illness is out of control, when they realize that their loved one isn't safe at home or can't go home.
Okay.
This is Christina with First Choice, and I really applaud the families that are thinking ahead when we're talking about planning, and let them know that it is amazing that you're thinking about this now and you're trying to put some things in place for when and if there is an emergent situation. You already kind of have the groundwork started. But Alice is exactly right. I think a lot of the referrals that we get are in crisis. They're in the hospital, and now they can't go home, and they need a place to go. And so it's fast and rapid. And I think that all of us work, to whatever the timeline looks like. So if it needs to be right around, I'm working through the weekend, we're getting it done. If it's something that's longer term, we can take more time with it. Then we're going to pace with what the family needs. And Julie brought up a really good point about family dynamics too. So I think that we have to be really great at listening for who's calling the shots, who's really in charge. How do we bring everybody together to make sure that the goal is met to get care for their loved one?
Okay. So Tamara, where do your referrals come from? Do I still have Tamara?
Yep.
Well, she looks frozen.
Well, I will let you ladies answer that question.
Sure. Alice, you want to go first?
Referrals. Social workers, case managers. I've been getting there from APS, from word of mouth. I do get a lot of word of mouth. Hospitals. That's mostly doctors' offices. Anyone, churches, anywhere where they're in contact with seniors and their families, and they get asked questions or they notice something. That's where mine mostly come from.
Yeah, for sure. We've got skilled nursing that will refer to us. Like Alice was saying, that both of our hospitals refer to us directly for supports. Word of mouth. So I'll have a family member that I helped last year, and they'll say, oh, my friend needs help, and so they recommend me because I did a great job. And so that word of mouth is really important. We've all made great partnerships with our community partners. So people that do manage moves, they're in Portland, they do work in Vancouver. And so I'll get a call saying, hey, I was helping this person do some downsizing. She really needs some assistance for placement. So okay, we're on it. Or our communities, so assisted living communities might identify somebody that no longer is appropriate in that particular setting. They need memory care, they need more. Ooh, I look like a ghost. And so we drop in there and get that going and try to sort that out for our community partners.
Okay. Tamara, you came back, and now I lost you again.
Oh, there she is.
So my question is you've been at this longer than our other ladies, and what I'm wondering is what you have seen change over the years related to placement. Did you hear that question? Tamara?
I'm just now starting to hear, Lynn.
Oh,
I've
sorry.
been booted off the whole time.
I can tell that you've been bouncing back and forth. So my question was, because you've been doing this for such a long time, what do you see the changes in the placement arena over the last number of years?
Oh my goodness. Well, I've seen changes financially. Things have gotten more expensive, so people are waiting longer to be able to make plans and make changes. That's a big thing, and that's not just even in corporate communities, but also in private homes. Costs have just gone up, and pricing has gone up, and budgets don't always match. So people are holding off longer than they should. And then we get calls from people. I had a call a week ago from somebody that said, he's going to kill me. I'm going to die before he does, because I just can't do this anymore. And that's how long some people are waiting. Christina alluded to people having a plan. We do love that. We do appreciate those that are thinking ahead, and when the time comes can afford it. But over the years, it's gotten a little bit harder because people waiting longer then are coming in with greater care needs and needing more dollars to afford the placement. So the solution to that is not to wait until the very end, because when an adult, I'll use an adult family home more than a corporate facility like or community like an assisted living, memory care, that type of thing. If we're looking at an adult family home, we can go in at a certain level and perhaps work with a budget even as the care needs get larger and harder, because that provider has learned how to care for that person and not taken them on when they're at such extreme levels. They're already acclimated. So I think that's what's happened over the years, though, is that people have put it off longer, keeping people at home. And even with the suggestion of home instead or Elfin, certainly CDM, that type of thing, that CDM has a lot of clients with Medicaid, and referral agencies can't work with that arena the same way. There's ways we can kind of go around it, but we can't work directly with people that are on state assistance. We don't decline them information, but it's another whole situation. That said, waiting too long and not taking the advice of those that are giving help in home, and we see that being put off. It's not wise to wait till the budgets are needed to be a lot larger and the spouse or whatever caregiver is near dying before the one being cared for.
So that speaking of finances is one of the questions that we have is what financial resources are there besides Medicaid? Are there any? And that's all of you. How do we pay for this care that's needed?
Well, I'll take that. Long-term care plans, which not a large percentage of folks have, are really right now the only thing that covers it. Private pay, or until you run out of funding, and then Medicaid can pick up that care cost. But there are grant programs but that just is, that's almost lottery type. You can't count on a lottery to pay for your care. But yes, this is it's private pay, Medicaid, or long-term
might
care.
have VA benefits, and that might help. And so we are
That's
all
true.
very well versed at helping people get connected in that lane, but it's not an immediate solution. So you have to find a provider that's willing to wait for that payment potentially to come in to support. I just talked with a gentleman who's planning to cash in his life insurance policy because his life expectancy is less than 3 years. So for him to pay for long-term care in a setting that will be appropriate and give him what he needs, in his best choice for him is to cash that in so he can pay for the level of care he needs. Of course, family dynamics are involved in that decision too, and how people feel about that. But crowdfunding, I mean, some people have been really creative about trying to help bridge the gap until other monies come together. And so we do refer to financial planners and other resources to help people identify how they might take care of those costs. But it is really tragic and sad when we have a situation like Tamara was talking about, somebody that maybe it's a quick spend down, they don't have enough money to pay the 2 years that are required by some communities to be able to, switch them over to Medicaid. And so we have partnerships and talk with people about, hey, I've got this situation, I'm not getting paid to help do this. This is not, what we do for Medicaid, but are you interested? Here's the rate. And so, Tamara and Alice and I, we all do that connecting and trying to help. If somebody lands on our radar and this is what their answer is, we don't, like Tamara said, we don't turn them away without giving them some support and information about how to go through that process, which is a different webinar in its entirety. But we all do it because it's the right thing. And we're all here because we want to do the right thing, and we believe in karma, and that comes around, goes around, and you do it out of your heart for helping. So
Can you give a quick and dirty why placement agencies can't place Medicaid patients?
That's just the state. That if we, as Alice talked about in the beginning, we have relationships with providers, whether it be corporate providers, assisted living, independent living, memory care, or whether it be adult family homes. These are all, we all have a contract with those places. And when we bring a qualified resident, in other words, when we're matchmaking and we have the right fit for that place, which is what our jobs are, is to make sure that we're not just going anywhere and saying, here's somebody, let's fill a bed. We are about making a match for the right care level, the right personalities, all of that. We put all of our heads together for that. And then that provider, because we've done the work for them as far as bringing them what might fit for them, they are contracted with us to pay us a referral fee. So if it's a state, somebody with state assistance, the state has determined that if we take somebody's family, if we take that person to a place, and that place, which I'll just add right here, has a marketing fund. They all have their own marketing fund, but the state doesn't see it that way. They say that that provider is paying us with state funds. And we don't see it that way, but we can't argue with the state. So the state has made it illegal for us to work or even refer information basically to a person getting assistance with state aid that that we would then be reciprocated for. I mean, some of it is real, just real tweaky. I mean, why we can't give them exact information or even tour them, even if we don't get paid, if that's our choice, but we're not allowed to.
So the state kind of looks at it like, well, they're on Medicaid and there are social workers that are paid through the state to help these folks. But we all know that when one of our Medicaid families gets handed a packet of 400 adult family homes, it's over.
That's how they help.
And they don't know how to start. And so you're right, Tamara. I will say, let me give you some ideas and let me help you navigate through this process. And so if I do reach out to a social worker and they say, well, but you're not getting paid. And I said, but this family needs help. And I am here. I'm here to help. So we do what we can, and following the letter of the law. We don't get paid for those, but we also, we're not built to say, sorry, call somebody.
Right.
So
one of the things I do and always have as an advisor is to really coach and empower that family to put their social worker to work.
Yeah. Yeah.
That's what they're there for.
And then we just listen, and they'll call, we try to work with the family on this side to help support them through that process. It's a challenge.
So when you have kind of selected a community or a home that you think might be appropriate, do you recommend bringing that individual to visit?
Absolutely.
Well, with the current restrictions, the adult family homes are not allowed to do tours. Some of them are, and some are not, and some are allowing outdoor visits. So again, being creative about what a provider is comfortable with, we can try to do that safely. But definitely, we would love people to visit, and some of our communities are allowing like outdoor courtyard visits now. So some things are loosening up, but it's certainly not pre-COVID where we could just go right on in and it's just super easy. I think all of us offer opportunities and ideas, and here's some matches that we've talked about, and talk about the pros and the concerns and one over another or whatever. But we're neutral about providing options for people and not recommending, because this is their choice, and we're here to give them as much information as we can so that they're fully informed for them to make a choice.
Okay.
We give options.
Yeah, I was going to say, I'll add in too that what Christina's saying, that we don't like to pick a place and say, here, this is it. We're referral agencies. We're not placement. We're not taking somebody and putting them somewhere and saying, this is the fit for you. We're giving them options because that's their choice. And with different personalities, which is also something that I've always tried to do, and working with Kathy and Tricia in the past, we like options so that different personalities can be identified. And as far as visiting a place before, not always so wise with dementia. Families, yes, pre-COVID and hopefully post, but those with dementia, we don't recommend that. And I'm talking about not just early onset, because generally speaking, early onset dementia they're not moving yet. We're still working in home, with them, the agencies. But when we get further along and the dementia is where it is, I don't personally recommend that family take them there to visit. That just is confusing all the way around. There's ways to go about, kind of going back to what Julie said, how we get creative as to how to get them to go there at all, just to start the whole move and get the happening to be without an event. And that isn't always, we still have events because of the move, but we try to be creative as to how the move-in would happen, but not a pre-visit per se, like someone who we might help find a place. We might refer a place to somebody that is recovering from stroke recovery or something like that. And they can go in a wheelchair, they can go visit, they can go see that provider and visit. Absolutely. Then go have lunch with wherever they're considering to move in, for instance. But with dementia, it's different.
So senior advisors, do you do an assessment of the senior that you're placing? So you don't
Absolutely.
what the family tells you.
Well, I think it's a combination of any kind of information that we can get. So I'm talking with the family. If the older adult is able to participate, I may be talking with them as well about what they think is going on and helping to support that effort. Sometimes it's care managers, sometimes it is a physician, doctors, whoever's involved to give us input about what's the best kind of plan, which way should we go? Should we be looking at adult family homes, or is assisted living appropriate? Where are they going to get the best care based on their finances as well?
Okay, that was my question, is how do you determine an assisted living versus an adult family home? Those kind of things. Is it based on level of care? Is it based on ability to pay? All of the above?
Mm-hmm. And
All
their
the above.
activity level and how social they are. There are a lot of factors that come into play.
Yeah, some communities aren't equipped to manage certain types of medical care. So in that case, then it does look like maybe adult family home would be an appropriate option based on the needs that they have. But if it's somebody that's, in their 60s, that's a real challenge for us to try to find an adult family home that has people that they would be able to visit with and chat with, if they're more social. So we do have to dig and really find out what's going on with this individual so that we can find a good match and make sure that they could be thriving in whatever home they choose next.
So prior to COVID, do all of the senior advisors visit the various adult family homes? Do you attend
Yes.
adult family home meetings so that you get to know these providers?
Yes.
Kind of things? Okay.
Yep.
And we have a question about, all this talk about payer source, which is terrifying. Often people will need to have a family member provide care. And so the question is there a way for that family member to be paid? So I'm wondering if our
there are resources out there. I do have one individual that was providing care to her family, and she was able to figure out through the state how to be paid as a caregiver. But it's complicated. Nothing is easy, and you need to be able to pay that person like a caregiver and do payroll kinds of tasks, right? Julie, you're nodding your head like, yeah. So it scares people about that, but it certainly is an option.
okay. And who could coach the individual who is looking at having a family member become a COPS caregiver, for example?
Well, they would go through the home care aid training like anybody that got hired. So I think that, at least what I understand, is they're required to go through the home care aid training as well. So then if that family member passes, and they've got the training, and they can go to work for CDM, right?
Right. CDM has a referral agency on site, and they can reach out to, they have an IP referral service, and we've had family members reach out, but there is a strict criteria. I don't know all the criteria for it, so I don't want to misquote, but you just would call the main line and then ask for the referral service, and they can walk a family member through that.
Okay. So do the home care agencies ever refer to a placement agency and vice versa?
Yep, all the time.
Absolutely, all the time.
All the time.
So when, for example, when the home care agency identifies the fact that the care is becoming too great and too expensive, you would make that recommendation?
Mm-hmm.
Yes. Yep.
And then a lot of the calls we get are really,
Right.
they're really asking for home care, and so then we refer those out.
Yeah, we get a great deal of those calls. Just going to say that.
Probably more recently, right?
Absolutely.
Mm-hmm.
Yeah.
So do you have tips on what to look for senior living visits and now I'm sure they're virtual visits or whatever. and what kind of questions to ask from our placement agencies when you made a recommendation? Do you coach the individuals? And
Well, I always tell them they should eat a meal there and check out the food.
The food's
Number
pretty
one.
important. Yeah, that's a number one. People want to know about the food.
Yeah.
Yeah.
But it's based on individuality. So I'm coaching the family what to ask based on that assessment that we all talked about, or that Christina pointed out, those things. I mean, at one time we had a client that was not going to leave his farmhouse. So we had to find an adult family home that was something that was going to appease him. So we found llamas. I mean, we do whatever we can to make that fit. So we have to try to coach that family based on what their expectations might be, what they should be, and what questions to really ask, removing a personal choice over to what would mom or dad, what would spouse be happy with, not me.
Mm-hmm.
So, yeah, there's a lot that goes into it, but there's a lot of coaching.
Yeah, coaching is a good word to use, because I think we do try to set our families up to be successful.
Yes.
Give them the tools that they can, kind of lead the conversation. But then we're standing in waiting to jump in and, hey, I know this was important. Can you address it?
Right. Based on the assessment, you find out what their preferences are and what's important to them.
Yeah.
This is the sad part about not being able to tour with the family, because nearly every single tour, a family member would forget to ask a certain question, and I'd be able to just kind of inject it in as a kind of, asking the provider, and they'd go, oh yeah, I meant to ask that. But in this case, we have a sheet with some really pertinent questions for them to go over and ponder, but then we coach them as to what to ask for that particular individual.
we're very close to the end of our time, but I wonder if you all have a perspective on aging in place. If you had one recommendation to make related to aging in place, what would it be? And I guess I would just go through all of you and ask you, put you on the spot and say, what would you recommend related to being able to stay in your home?
Be proactive and be realistic. Understand what the costs of and the reality are of care at the late stages of life, and can you afford it, and is that the way you want to spend your money?
Okay.
Yeah, having a plan, having that advanced care planning and knowing every step of the way. And I would say including your animals, making sure everything's covered, and going back to what Julie said, being realistic.
Well, and I'm with Julie, Tamara. I mean, I think we're probably all going to say very much stuff, but I think for me, the biggest thing is really that plan. Most of my background, most of my background comes from my years as a fiduciary. So estate planning. And that includes things like, I'll say this, along with your pets, make sure you're deciding what happens to your personal property. That's another huge thing. What are you going to do with all that stuff? So when you are thinking about aging and moving and all those things that are going to come at some point, if you do ever have to move, start cleaning up your stuff now, because I've been in a lot of homes where you wonder, why did you keep all this stuff for 80 years? So planning is important. And then I think the other big one is digital assets. In the world of technology nowadays, digital assets are huge. So making sure that you also have a plan in place for things like, again, that you wouldn't really think about, your Gmail, your Yahoo, your Facebook accounts. A lot of that stuff is done virtually or online, and so now that's a big part of what's built into that estate plan.
Right.
So when the home care agencies go into a home, do you make recommendations make safety recommendations, or if you feel strongly that that individual may need to have OT or PT, things like that. You make those recommendations, do you?
I mean,
Yes,
Outside of you?
yes, we do. Especially if we're going to be providing like a bath in the home, and we see that really they would be benefiting from a bench or a grab bar or a ramp. We're going to make those recommendations just so the caregiver and the client are safe when we're providing that care.
and I think just to chime in on that, I think that yes, we make those recommendations, and I'm only chiming in because you sort of use the verbiage of a strong recommendation. My goal is never to force anybody to do anything that they don't want to do. I think that's like a big thing for me is like, we of course are huge about recommending things and saying we think this is in your best interest and all that. But my big thing is people are going to live the way that they want to live. But at the same time, if it does put our caregivers or our employees in a situation where it's no longer safe or it's a risk or a huge liability, obviously, then it's a whole nother story. But that's the thing too, is that it's our job as an agency to go in and make recommendations and to guide people. But at the end of the day, it's not my decision. It's not my job to live their life for them. It's not my job to make those decisions for them, especially when you've got family involved. Our job really is advocating and recommending certain things, but ultimately leaving it up to the person to make those decisions.
If a home situation is clearly unsafe, what would you do about it?
So if for CDM, we actually involve the case manager, but also if it has to do with the caregiver feeling that the client's actually self-neglecting, it becomes an APS report. And that's, for us, that's huge. We have a lot of self-neglect and lots of calls to APS because of it, no matter what kind of interventions we've tried to put in place.
Okay.
Very good point.
Yep, that's the same for us. If it's not safe, we reach out to whoever that, APS, and then maybe the police if we feel like that's the case. But yeah, reaching out to some agencies for help.
And we're talking, that's a special case, you know what I mean? That's a case that doesn't always come up, but certainly those are the ones as mandatory reporters where, we're making the call. And of course, it's always the question of, well, I feel bad. Should I even call? I don't want to cause any problems. Well, again, I teach you're a mandatory reporter and we're reporting in good faith. So if you're concerned for somebody's safety, you should be calling no matter what.
Absolutely. Well, our time is up. Thank you all so much. Is there any final word before we cut you off? That was extremely helpful. Thanks so much.
Thank you for having us.
Thank you so much.
Thank you.
Thanks.
Before we leave, I want everyone to know that next month our education will be by Joyce Beadle, who is an Alzheimer's educator out of Portland. And
she's great.
The topic is going to be dementia and sexuality. So she really is a really good speaker. So we're looking forward to it, and please come.
Sounds wonderful. Thank you.
Thank you.
Thank you.
Thanks, everybody. Good job.
Thank
Bye-bye.
you.
Thanks.
Bye.
Bye.